I appreciate the chance to get to introduce Dr. Christine Dehlendorf this morning, a person who has influenced me a lot in my research and thinking. Dr. Dehlendorf is also our keynote speaker or one of two keynote speakers at the Contraceptive Care Summit tomorrow. So we're very fortunate to have her at Grand Rounds today, especially when it is 6 a.m. in California. So thank you to her. I want to say a few words about Christine before she takes over. And I'm going to bring up my notes. So Christine runs this fantastic research group out of UCSF on person-centered reproductive health, and I'm going to put it in the chat. This is a really exciting program that Christine has developed and has had several amazing steps in the process. So Christine is trained as a family physician, has a fellowship in family planning, and her center on patient-centered, person-centered reproductive health has the mission of advancing reproductive autonomy and really integrates patient experiences to guide health and healthcare. I also really appreciate that she and her colleagues attend to intersecting oppressions and structural injustices in this work. Some studies in this process that I have a real crush on. Dehlendorf and her colleagues recorded 342 contraceptive counseling visits and then follow these participants for 6 months and really examine some of the impact of patient-centered counseling on contraceptive use, as well as the real value in shared decision-making, which I imagine she'll talk about today. I've also really admired the way in which she's used her research to develop a tablet-based contraceptive decision tool called My Birth Control in collaboration with the National Campaign to Prevent Teen and Unplanned Pregnancy. So this really great patient-facing aid, and then has done a cluster randomized trial of this intervention funded by PCORI. And most recently has led in the development of some measures for use in reproductive health research, including what's called the interpersonal quality of family planning care scale. And I very much hope this will be a scale that we all get to use, or many of us get to use in our own research and clinical care. She got her undergraduate degree at Stanford, her MD at University of Washington, and has been at UCSF ever since. So delighted to pass it over to her and take it away, Christine.
Great, thank you so much, Jenny. The appreciation, personal and professional, is so mutual. So thank you so much. It's great to be here. I just wish I could be with you all in person. On that note, anyone who feels like turning on their video, no pressure, but it's so nice to talk to faces, especially when it's 6 o'clock in the morning. My coffee is kicking in, so I think I'll be getting more animated over the course of the talk. So I want to start by asking you all to reflect for a moment on your motivation for providing quality contraceptive care. As you reflect on that, I just want to realize I left the disclosures slide out that I think Lisa told me explicitly to include. So I have no disclosures, and imagine there is that slide there. I apologize. Okay, so your motivation for providing quality contraceptive care. What do you think about when you think about either you personally, if you're a clinician, or if you're someone who is doing other work related to OBGYN? What is your motivation for working in the field in which providing quality contraceptive care is valued? So when you thought about that, I ask you to think, did you think about preventing unintended pregnancies or unplanned pregnancies, which is a common thing that we talk about, or maybe preventing teen pregnancies, or maybe talking about preventing teen pregnancies so you can prevent future teen pregnancies? Or is it about cost, right? Because that's something that we talk a lot about when we talk about reproduction. Or do you think about people? Did you think about your patients? And did you think about meeting people's needs? Or maybe you thought about some combination of the two, and maybe those two things don't seem in conflict to you at all. So that's really going to be the kernel of what I'm going to be talking about, is kind of how these things relate to each other and how our field thinks they relate to each other and how we can move through that, what I think is a tension, and provide quality contraceptive care. Okay, so in order to get started, I want to make sure we're all on the same page of what we are talking about when we talk about patient-centered care. So this was a concept that seems, as you know, obvious as sliced bread, right? But it actually didn't really gain traction until the early 2000s. And if you look at a graph of PubMed articles where this was a term that was used, it's like takes off in like the, the early or the late aughts. And that was because the Institute of Medicine published a report, Crossing the Quality Chasm, in the early 2000s, in which they defined patient-centered care as one of the core dimensions of quality. And they said, and they defined it as care that is respectful of and responsive to individual patient preferences, needs, and values. So again, this seems obvious in the same way I think evidence-based medicine seems obvious, right? We should always be doing evidence-based medicine, but we also know that we often don't do evidence-based medicine. And similarly, a lot of the care that we provide is not in fact always patient-centered. And one of the examples I often give, and this you'll understand all this, is people who provide care for people with diabetes in the context of their reproductive lives. That in the care of patients with diabetes, I'm a family doctor, so I do this a lot. In the care of people with diabetes, we often focus on hemoglobin A1C. I get performance metrics every quarter based on how many of my patients have well-controlled diabetes based on their hemoglobin A1C. That is the metric that our institution uses and that the broader system uses to judge whether I'm providing high-quality care. But is that in fact patient-centered? Is that ultimately what the patient themselves care about? Or do they actually care also about episodes of hypoglycemia leading to emergency room visits, pill burden and side effects, the number of shots they have to give themselves? And they also care about their long-term outcomes, but it's all part of this broader context of their lives that isn't captured in hemoglobin A1C. And so patient-centered care is really care that takes into account that broader context and doesn't just focus on narrow either clinical or public health priorities that sometimes we tend to zero in on in the care that we provide. And then very much historically has been the way that care has been structured and prioritized. So what do we know about patient-centered care? Well, one, we know that it's an ethical mandate, right? Like we are serving people in the full context of their life, not just their lab values. So it's very much something that we need to be focusing on as a core, or I would argue the overarching dimension of quality. In addition, we know, not surprisingly, that when we focus on quality, on patient-centeredness, actually patients do better with respect to these broader, their broader clinical outcomes, right? So when we focus on patient experience of pill burden and hypoglycemia, they can do a better job of taking their medicines and their hemoglobin A1C is lower. So it's not an either or scenario. It's really, we have to be ethically paying attention to patient preferences. And it turns out that when we treat people as people, then they actually do better in clinical outcomes as well. And I do want to reference the fact here that when I use the term patient-centered care is kind of the word of art that is used in our field. As Jenny mentioned, I've titled my program Person-Centered Reproductive Health Program, and I kind of use those terms somewhat interchangeably, but I really prefer the person-centered language because it acknowledges that people aren't just patients. We're not just caring about them when they walk in the door and we're caring for them, we're caring for them in the full context of their lives. And I think that is particularly important in the context of reproductive health care. Okay, so is this concept of person-centered contraceptive or reproductive healthcare novel? Is it actually anything exciting to say that I need? I mean, that's a question open for debate. But is it novel to call my program Person-Centered Reproductive Health Program? Well, I think there's a broader conversation there that I had to cut about, in general, the way that reproductive health outcomes are considered through the lens of societal priorities and considered as something that can be operationalized to achieve societal and economic goals, as opposed to things that are embedded within people and that in fact are about people's lives and their experiences. But in the context of contraceptive care specifically, which is what I'm talking about, we need to focus in thinking about whether or not our care is person-centered. I want to focus on the movement that has happened over the past decade and a half towards promotion of LARC methods being one of a frequently either explicit or implicit tenet of family planning care delivery and family planning services. So these is based on the fact that LARC methods, when they kind of IUD resurgence happened in the aughts, and then Implanon and then Nexplanon was approved, these methods are highly effective methods, more effective and less prone to deficits in effectiveness related to having user lack of consistent use, right? So we saw this big movement towards promoting these methods, and examples of counseling approaches that promoted these methods include what is called tiered effectiveness. And that's where you really start with the most effective tier and you move downward, but you really emphasize the first tier and you come back to it and you mention it first from kind of a behavioral economics perspective, that things that are mentioned first are things that people are going to be more likely to prioritize. And that's the LARC first model that's here. And the image is from the Choice Project in St. Louis. And there's IUDs and implanons embedded in the flowers there. Another approach that's been used is motivational interviewing, which is this idea of motivational interviewing, as you probably know, was a approach to counseling that was developed in the context of addictions, with the idea that we can't just tell people to not use substances. We need to help them and support them to figure out why they want to stop using substances, because that's going to be much more likely to produce sustainable change than just being told what to do by a healthcare professional. So it's a patient-centered approach to directive counseling. And it's been applied in the context of contraception to, quote unquote, help people overcome their ambivalence to use of IUDs. The other image here is from a LARC initiative, a contraceptive access initiative, which has been very focused on LARC. Many of you know that there have been many efforts around the country to fund contraceptive methods. And this was from the South Carolina initiative. And this is a public-facing message that used the British motto, keep calm, but replaced carry on with get a LARC. Okay, so we all see this in our care, right? I'm not sure exactly what the context is in your all clinical practices, but I can say even in San Francisco, where we've been talking about this for a long time, this is still something that very much is part of our clinical milieu, that there is providers feel like they've succeeded or they've failed if their patient does or does not choose to use a LARC method. And this is particularly true among patients who are, for whatever reason, considered high risk. And I'm going to come back to this concept of high risk and how that can lead into bias, but patients who use substances or patients who haven't had enough prenatal visits. And so all of this, our kind of desire to promote these methods and our sense of our own clinical efficacy in providing these methods can track on to our perceptions of our patients. So I've had residents come up to me and sheepishly tell me patients have chosen to use the pill instead of the IUD, thinking that I'm going to criticize them as they're attending for doing that. We all know that there's references by the American Academy of Pediatrics and ACOG to LARC methods being first line, that language. So that's very much consistent with the tiered effectiveness approach. And we've also seen a lot of studies that increasingly have documented the lived experience of patients in experiencing resistance to getting, when they choose a LARC and then they want to get it out, experiencing resistance to getting it out, which is a form of it's directive counseling and coercion at the same time, because in that situation, we're not just trying to promote the methods, we're actually refusing to honor patients' bodily autonomy by removing a method at their request. Just even the language that we often use, removal on demand, is one of the things I've heard, which is so problematic. Patients don't have to demand their methods being removed. It should be removal on request. Okay, so I've already probably telegraphed how I'm going to answer this question of, is focusing on contraceptive effectiveness using directive counseling? Is this a patient-centered or person-centered approach? So this is based on the prioritization of method effectiveness, this prioritization and promotion of IUDs and implants as the most highly effective reversible methods, is based on a desire and prioritization of preventing unintended pregnancy. That is the rationale behind that. And that is because we have a dominant public health paradigm, I say here, but it's actually really a dominant clinical paradigm as well, that an unintended pregnancy is a bad pregnancy. And therefore, it is our responsibility from a clinical perspective, from the do no harm, do the right thing for our patients. Our job is to prevent unintended pregnancy. And therefore, it follows that promoting these highly effective methods is a good strategy. But it's important for us to think about, does this dominant paradigm, which has been around since a study in the post-war period in which the unintended pregnancy framework was developed in a suburban group of white women, it's a long historical story, which is quite interesting, in which so much of our clinical and public health care has been structured since then. How does it reflect whether or not how people think about pregnancy in the context of their own lives? Is this paradigm actually reflective of people's lived experiences? So I often do a poll here, but polls are harder in WebEx than they are in Zoom. So I just ask you if you want to put if people want to put in the chat whether or not or just reflect for yourself. Is an unintended or unplanned pregnancy always a bad thing? reflect on your own experience, reflect on your family and friends' experiences, and reflect on your patient's experiences. Okay, so what does the literature tell us about this? And I just want to honor one of the things that I feel very strongly about as a researcher in reproductive health is that we have to honor that research can tell us a lot, but lived experience tells us a lot as well. And so we have to honor both of those things and how research reflects or doesn't reflect lived experience. So what does the literature, though, tell us about this? So again, the dominant paradigm is that intentions and plans are what determines how we should think about the potential for pregnancy in the context of a person's life. So intentions are timing-based ideas about if and when to get pregnant, and plans are then how you act on those intentions and decisions that you make. And this has been the paradigm. We still ask, like I have a former staff member who's getting her PhD in social work, and she has to ask in California, every patient at every visit she has who's pregnant, whether or not their pregnancy was intended or not. Up to 30, like she's still seeing patients at 36 weeks and she has to ask patients. It's like, that's how embedded it is in clinical care. And this particular patient she was telling me about burst into tears when she asked. So it's not a harm-free intervention. So what else factors in to how people think about pregnancy in the context of their lives? So one is desires and the other is feelings. So these are, again, these are constructs we put on complex phenomena, but it helps us to at least recognize that it's more complex than only intentions or plans. So the things that have been described in the literature are desires, which is the strength of the inclination to get pregnant or avoid pregnancy. Like, do you really, really, really not want to get pregnant? Or are you kind of like, well, and I'll show you an example of a quote from that in a second. And then feelings, so emotional orientations towards pregnancy. So especially with the intentions versus feelings piece, if we're using a rational actor model, the argument could be, and I think has implicitly been, that these things are all aligned. If someone's planning to get pregnant, they'd be happy if they get pregnant. If they're not planning, they would be sad. But what the literature tells us, and our lived experience, is that in fact, feelings about pregnancies are complicated and these things don't always align, right? It's not a rational actor situation when you're talking about reproduction. And so these are all different concepts, and individuals may find some meaningful and others not, and they may appear in a rational actor model to be inconsistent with each other. So again, reflect on this with your own lived experience, but to give you some idea from the data, how we can understand this through people's own voices. This is a quote from an amazing study performed by Dr. Ginny Higgins that was in Perspectives for Sexual and Reproductive Health in 2017, where it really gets at how people's feelings about pregnancy can be complicated. So this woman said, I guess one of the reasons that I haven't gotten an IUD yet is I don't know, having one kid already and being in a long-term committed relationship, it takes the element of surprise out of when we would have our next kid, which I kind of want. I'm in that weird position. I just don't want to put too much thought and planning into when I have my next kid. So thinking about this from the perspective of the unintended pregnancy framework, if she were to get pregnant, it would be a bad thing. But obviously, from her own lens, her own lived experience, that would not be the case. So there is a disconnect between our framework that's often used and her own perspectives. I often have to cut slides, and I did, of all the quotes I could use to demonstrate these concepts, but I wanted to use this one from Anu Gomez, who's at UC Berkeley, also on Perspectives in Sexual and Reproductive Health, which really demonstrates the concept that people have indifferent or ambivalent desires as well. So I already got a kid, so you know I'm not opposed to having children. If it happens, it happens. I prefer we don't have children right now, but if it happens, okay. I always include this quote because I know that as clinicians, ambivalence makes us super uncomfortable, right? And when we talk about this data often, the argument that comes out often is, shouldn't we get people to plan for their own good? So if this last patient is ambivalent, the other woman is a little bit hard to put into a box. But if this one's ambivalent, shouldn't we just counsel into having a firm intention? Because intention is so important in terms of the clinical outcomes that we expect from a pregnancy. So this makes it important to answer the question, is unintended pregnancy a universally negative health outcome? What do we actually know about the research? Again, lived experience-wise, I think we all know plenty of people who've had unintended pregnancies who have good outcomes, and plenty of people who've had unintended pregnancies who have bad outcomes. But what does the literature tell us? Well, basically the literature tells us that. So just to go, there's a lot of reviews that have been done about this. And what it tells us is that despite this dominant paradigm and the fact that I have written innumerable grants that lead with unintended pregnancy is associated with negative maternal and child health outcomes, I don't do that anymore, but I have many times. Despite the fact that that's the claim and the kind of common understanding in our field, it's just not true if you dig into the literature. Most studies, in fact, have shown no association with social or health outcomes. And while there have been some that have done that have showed associations with low birth weight and preterm birth specifically, that is generally isolated to what's called unwanted births, so not mistimed births. So people who never wanted to be pregnant again and became pregnant, right? In addition, many of these studies and all of the meta-analyses that have looked at these have been uncontrolled for confounders, right? And that's because they often don't have the data that they need. These are all retrospective and they don't have the data that they need to appropriately control for things that are both associated with pregnancy intention and associated with pregnancy outcomes. So I actually find it quite striking that despite the fact that we can't control for those things, still most studies show no association with social or health outcomes. In general, and also really importantly, is most of these studies are retrospective because it takes, recruiting a huge group of women and then following them prospectively per pregnancy is a huge study. So most of them talk to people retrospectively, including all the National Survey Family Growth studies that document pregnancy intention. And what happens if you have a bad pregnancy outcome where you were kind of ambivalent? Are you going to be more likely to report that it was an unintended pregnancy versus if everything's fine and you have no problems and your relationship has stayed intact, et cetera? So this retrospective intentions is a huge threat to validity in these studies. And overall, what this tells us is that unintended pregnancy is not clearly the end of the world for a lot of people. For some people it is. I want to honor that. For some people, it is the end of the world. And for some people, it's a happy accident. And by grouping it together, by saying intention is the nexus on which we should judge whether a pregnancy is a good pregnancy or a bad pregnancy, we are not honoring the complexity of reproduction in people's lives. So through that lens, with that analysis about unintended pregnancy, I want to ask, is directive counseling patient-centered? So we could just say no at this point, but I kind of want to walk you through how I think about this because I think it's important to think about how we provide counseling in general and then apply it to contraceptive care. So I just want to say directive counseling from a patient is not inherently inconsistent with a person-centered or patient-centered lens. And in fact, we do directive counseling a lot of the time. When my patients are smokers, I would prefer they stop smoking, right? Because that's better for their health. But I still can engage with them in a patient-centered way. And that is, in fact, that honors their values and preferences and lived experiences and the motivations that they may have for smoking. And that is exactly the reason why motivational interviewing was created in the first place, was to be able to perform directive counseling in a patient-centered way, right? But in contrast, there are decisions, unlike smoking, where we know that there are poor health outcomes associated with smoking, with poor diabetes control, et cetera. There are conditions and clinical scenarios where we don't have a strong clinical agenda, right? Where the decision is more complicated and there isn't one thing that we're putting our money on, that this would be a better choice and we want to engage with your preferences, but we know where we would like you to end up. And those are considered preference-sensitive decisions. So some examples here of things that are kind of prototypical preference-sensitive decisions. In those scenarios, our role as providers is to provide decision support, which helps and supports people to consider how the different options relate to their own values and preferences and will play out in their lives. To be clear, we should also be providing decision support when we're doing directive counseling, but there's just a fairly different flavor of us having an agenda versus not having an agenda. So what kind of counseling is appropriate for contraception? So I have these two pictures up here because I want us to reflect the way the directive counseling model basically equates using condoms with continuing to smoke, right? It's saying that using LARC is like stopping smoking and using condoms is like continuing smoking. Like that is the narrative there in terms of what a better clinical outcome is. Even using pills is like continuing to smoke because you're not using a LARC method, right? And we know that smoking is associated with heart attack and stroke. And we know that the condom's decreased efficacy is associated with unintended pregnancy. So it's basically equating a stroke with the unintended pregnancy. And my argument is that an unintended pregnancy can mean very different things in the context of people's lives, whereas a stroke generally means generally the same thing in the context of people's lives in terms of morbidity and impact. So just to put this really clearly, we know women have strong, and there's studies on this, I've cited some of them here. We know women have strong and varied preferences for contraceptive features, and these relate to the different assessments of potential outcomes, such as side effects, such as how they use the method. And then the other thing that people care, some people will have differing priorities around, is the importance of avoiding an unintended pregnancy. And putting this together, what this means is that this is a preference-sensitive decision for which decision support and not directive counseling is appropriate. So another thing I just want to highlight is that the directive counseling approach, like I said, the concern is that it doesn't honor the preference-sensitive nature of contraceptive choice. Also, from an ethical standpoint, going back to the title of my slide, it doesn't prioritize autonomy. It doesn't prioritize people's abilities to make their own informed decisions about their bodies and their lives, and instead uses, like I said, this behavioral economics approach to try to encourage people to end up on a certain path, which I think is inconsistent with the care we should be providing in reproductive health. So this alone should be enough to make us not provide directive counseling around contraception. But I also just want to say that even if I haven't convinced you and you want to, and you still think everybody should be using an IUD or an implant, the reality is that providing counseling that puts pressure on people is actually counterproductive to those clinical outcomes. And we have studies, including studies that our team has done, showing that perceiving pressure appropriately makes patients worry that they're not using the right method for them, and actually is associated with dissatisfaction and method discontinuation. And just to give you a sense of kind of how patients themselves actually experience this type of directive counseling and why this is the case, this is a quote from a study in South Carolina that was embedded in that initiative that I had, the Keep Calm and Get a Lark initiative, where they were really focusing on postpartum IUDs. And this Emily Mann, one of our colleagues, did a study interviewing women who experienced that initiative. And this one woman said, they just keep promoting these long-term methods. It's like they're getting a commission or something. I always wondered that. They were really, really, really trying to push this product. It was like they were selling me, like, you should try it. No, I don't want to. So this process of being sold on the method created appropriate reactance. The other thing we've really seen, I already mentioned the directive counseling related to IUD removals. Again, we've seen this literature really evolve, that this is something that is not uncommon experience for people to experience resistance to IUD removals. And I think it's another place where we can see the directive counseling really interfering with patients' ability to use the method that they want and realize their reproductive autonomy. So again, a quote from Dr. Jenny Higgins. I was telling the nurse I've been on my period for like 3 weeks now, and I'm having bad cramps, and I'm even having them in my back, which I never had before. And she was saying, just give it another month or so and see how it goes. I was mad. And then this is another study from my colleague Jen Amico in New York. I don't know if it makes them providers look bad if you have an IUD removed and they're the ones who placed it, or I don't know if they have some stat chart somewhere, like a contest board in the break room. So these quotes definitely make it clear to me that we are damaging trust with patients by not honoring their autonomy in the context of directive counseling. Okay, so to go back to that first question I asked you, what is the goal of quality person-centered contraceptive care? Is it to prevent unintended pregnancy? Or is it to meet people's needs as they themselves define them, and in that way honor their reproductive autonomy? To recognize and respond to the diversity of perspectives and desires about reproduction, and to communicate respect and build trust. And this is definitely my opinion. Okay, so given that, how do we provide patient-centered contraceptive care? So I've already so these are kind of, I'm presenting on this slide kind of the two poles of how we can have what's in the literature about how contraceptive care is provided. One is this directive counseling provider-led model. And then there's the patient-led model, kind of the what's called informed choice model, which is on the other end of the spectrum. So really briefly, I just want to say that's not what I'm arguing for, okay? So this kind of consumerist model or patient-led model is this idea that patients basically get a menu of options. We give them all the information they could ever need to make a decision, and we just, because we're so afraid of any sort of pressure or coercion, we don't participate in method treatment selection itself. this has been documented to be problematic in that for many patients, it doesn't support them in understanding how their preferences relate to the methods. We have a lot of methods. We don't have enough methods, but we have a lot of methods that are available. And it's complicated to sort through all that information. And so we're not tailoring information to patients' needs and basically leaving them with this huge, Cheesecake Factory menu of contraceptive choices that they have to then sort through themselves. Okay, so then how do we provide contraceptive care? So my argument is we take the best of consumerist counseling, which is really recognizing and promoting patient autonomy, and the best of directive counseling, which is to ensure patients are informed about method effectiveness and that patients for whom this is an important factor have the ability to make a decision incorporating that information. And we bring those two things together to promote a quality decision based on patient preferences. That should be our goal, to provide decision support and the information patients need to be able to make a quality decision. And in the healthcare communication literature, I'm sure you all have heard shared decision-making as a term that's kind of out there in the world. But shared decision-making is a very specific form of counseling that is different from motivational interviewing, because what shared decision-making is you use it when you don't have an agenda, and really your goal is providing decision support. So just to give you a definition of what shared decision-making is, a collaborative process that allows patients and their providers to make healthcare decisions together, taking into account the best scientific evidence available, including about effectiveness in this context, as well as the patient's values and preferences. And this process provides patients with the support they need to make the best individualized care decisions. And I think it's really important that it's a shared process, but it's still the patient that makes the decision. That's very important because we have clinical equipoise. And so patients, it's not a situation where patients are coming in and asking us to do surgery that we don't want to do, right? This is a situation where we have clinical equipoise and we're supporting patients to make a decision. Okay, so we've done literature in our program doing quantitative and qualitative analysis, including from that 342 patient study that Jenny referenced at the beginning, that have found that shared decision-making is consistent with women's preferences for counseling and that they have higher satisfaction when they experience a shared decision-making approach. Importantly, I want to reference that some patients don't want our support, right? We all have that. We all have patients who are like, I want the pill, and we screen them for contraindications and they do not want to talk to us, right? I am not saying a patient-centered approach is forcing every patient into a shared decision-making process, but rather providing that as a starting point. I'll go into a little bit more detail about that, using it as a starting point for counseling. So this is just a quote from one of our qualitative studies where this is where I kind of realized, had a epiphany that this was shared decision-making made sense from a family planning and a contraceptive care perspective. So this woman said, I just think providers should be very informative and non-biased, not try to persuade them to go one way or the other, but try to find out a little bit about them and maybe suggest what might work best for them, but ultimately leave the decision up to them. Okay, so I want to take a brief moment to reflect on this, what I've been saying in the context of health equity and racial justice. So hopefully you are all aware that there is a long history in the United States of reproductive injustices being enacted through family planning care delivery systems, including non-consensual sterilization, unethical testing of the pill, and targeted marketing of Depo. So given this history, we know that this history exists, and this history is reflective of something called stratified reproduction, which is the reality that the fertility of some people is valued by those who dominate social discourse and the fertility of other people is not. And there are formal and informal policies to enact these priorities. So these are things that you can see in welfare family caps, right? The things outside of family planning care delivery, but it's also something we see in family planning care delivery, that these policies and practices are reflective of societal priorities for who reproduces and who doesn't. And I really recommend Dorothy Roberts' book, Killing the Black Body, if you're interested in hearing more about the way that this has been enacted against specifically Black Americans over centuries. And she writes, the thing about reproduction is that more than anything else, it tells you how a society values people. And Dorothy is a legal scholar, and it's an incredibly well-referenced book, and but also very readable. So I just want to reference the fact that the reality of stratified reproduction was one of the motivating factors behind the creation of the reproductive justice movement in the early 90s by Black activists, one of whom is Loretta Ross, who will be talking tomorrow. I'm never more nervous before a speech than when I'm talking before Loretta Ross, but I guess it's better than talking afterwards. So I can't pretend to do anything to share the concept of reproductive justice that she is not going to blow out of the water, but I feel like I can't give a talk without acknowledging the debt that I owe to reproductive justice leaders who have really helped me to think about the way that family planning care and contraceptive care is embedded in this broader context in which some people can experience their reproductive autonomy and other people have their reproductive autonomy limited. And I think we just really need to think about all the reproductive health care we provide in this context. So how does this history and reality of reproductive injustices in family planning care delivery play out in the care that we provide? Well, there are studies that show that understandable mistrust exists as a legacy of this history, right? So this one study of 500 Black women found that over a third reported medical and public health institutions used foreign minority women as guinea pigs to try out birth control methods. This is not, conspiracy theories. This happened, and this is reflected in the mistrust of the care that we provide. Another study of younger women, this was in the last decade, younger women 18 to 29, that was done by Guttmacher, found that almost half of Black and Latinas think government promotes birth control to limit minorities. Again, not ununderstandable. We also can see this distrust, this history of mistrust manifested in different patterns of preferences for contraceptive methods by race ethnicity. And this is a study that Andrea Jackson at UCSF led that I was involved with, which looked at, this is a national sample of patients and where they're in the clinical context who were asked about their contraceptive method preferences. And what you can see here is that aspects of methods that were associated with control and not having to engage with the healthcare system were more likely to be highly prioritized by Black and Latina women than white women, including you can get it without going to a doctor, you have control over whether to use the method, and you can stop using the method at any time. And that is a very understandable legacy of the injustices that have been experienced by communities. But it's also really important to recognize that this experience of unequal care and bias is not just in the past. And this is something that we know in the healthcare community world in general, that what are called healthcare disparities, which are people being treated differently according to their socio-demographic characteristics, is something that is true and prevalent throughout healthcare. And this was summarized in another Institute of Medicine report called Unequal Treatment, again in the early 2000s, where they collated all the literature and summarized it by saying biases may exist, often unconsciously, among people who strongly endorse egalitarian principles and truly believe they are non-prejudiced. There's considerable empirical evidence that even well-intentioned whites who do not believe they're prejudiced demonstrate unconscious, implicit negative racial attitudes and stereotypes which shape clinical care. This is much less, I think, shocking to many people over the past few years than it used to be when this came out. This was quite revolutionary, but I think it's really important to realize that we as reproductive healthcare providers who care deeply about the experience of reproducing people with a capacity for reproduction, that we are embedded in this system in which this implicit bias and unequal care and structural unequal care is very much prevalent. So what do we know about this in contraceptive care specifically? There have been studies that have found that, for example, women of color are more likely to report being advised to limit their childbearing. Again, a legacy or a enactment of stratified reproduction. That Blacks are more likely than whites to report being pressured to use contraception. And once the same study of 500 Black women that I referenced earlier, 2/3 of Black women reported race-based discrimination when receiving family planning care. There have been studies and actually, so those are studies that talk to women about their lived experiences, which is incredibly important. There have also been studies that have looked at and surveyed providers directly. One by Andrea Jackson, who I mentioned earlier at UCSF, found that family planning providers do, when they use a validated survey for trust in their patients, they have lower levels of trust in their Black patients than their white patients. And this was a study that was actually done at San Francisco General among young residents and nurse practitioners who are working in the San Francisco General Hospital women's clinic. And these are some of the most social justice motivated people I know, and that this was still something that we found. There was a study that have found using standardized patients that found that providers are more likely to agree to sterilize women of color and poor women. And when I was a fellow back in 2006, I wanted to see, that was just at the point when this IUD enthusiasm was really taking off. And I wanted to see how stratified reproduction played out in the context of this IUD enthusiasm. So I did a randomized control trial where I had standardized patients that varied by race, ethnicity, presenting with exactly the same story using videos. And I showed these videos in a randomized fashion to providers at ACOG, at the American Academy of Family and American Academy of Family Physician national meetings. We were in the exhibit hall, gave free smoothies and chocolate to people who participated. And what we found is that providers were more likely to recommend, with exactly the same clinical context, with everything standardized, were more likely to recommend the IUD to Blacks and Latino women than to white women. So what does this tell us from a health equity perspective? We need, as providers, to be aware of both the historical context and the ongoing context in the way that healthcare is delivered and the way that it is not delivered equally when we're providing counseling. And we need, while we need to facilitate reproductive autonomy and focus on individual preferences when caring for anyone, we need to there are more barriers, and it is more likely that providers will not do that because of this context that we're providing care in, when we're providing care for women of color. So we need to set up a lot of ways, mechanisms of accountability and checks along the way to make sure that we center our care and our counseling on the needs, values, and preferences of the people that we're serving, and not let our bias affect the care. And I think I want to make the case that shared decision-making, which I'm now going to go on to describe, provides a structure for counseling that can help to protect against some of the impact of bias. I just want to reference this joint statement from the National Women's Health Network and Sister Song, which is one of the a very prominent reproductive justice organization, Sister Song, that when this a couple years ago, when there was a huge amount of concern about directive counseling that had risen to the surface, and for LARC method specifically, they put out this statement that very much makes the case that we need to be focusing on people's own needs and supporting them in providing the method that best meets their needs. Okay, so how do we do shared decision-making in contraceptive counseling? This is a whole talk that I give. It's like an hour, but really, really quickly, I'm going to go through it just to give you some idea. In doing that, I want to just acknowledge we all have biases. I've been talking the way racial biases about race, ethnicity can play out in the context of contraceptive care. We also have to recognize we have other biases. Maybe it's the 16-year-old who's just had an abortion. Maybe it is maybe it's the patient who is using withdrawal but hasn't ever gotten pregnant, but we still have a bias against the care that she's providing. Maybe it's because we really hated the ring when we used it, and so we don't want people to use the ring. Whatever it is, we all have biases. We all have triggers. We all have things that like cause our stomach to do a little bit of that. And that's being a person, right? But what we need to be as professionals and providers is we need to recognize that, and we need to counteract it consciously, right? So we have to acknowledge our biases and belief and work to keep them from influencing the care of our patients. So how do we do shared decision-making? So the first thing I always recommend is that we lead with not what do you want to use or what have you used before, but lead with a question along that explicitly doesn't just telegraph, but just puts it out there in huge red letters. We are going to focus on your preferences today, because patients are not used to that most of the time. So for example, asking a question like, do you have a sense of what is important to you about your method? So not saying, I want you to tell me what you're going to use so we can I can give it to you and get you out the door in 5 minutes, but I want to know what you care about. Most patients aren't going to have an answer for that, but you have incredibly importantly told them that you care about what's important. After opening that conversation, either you go down the path that they open in response to that, or you then lead with the process of eliciting their informed preferences for method characteristics, including, but maybe not limited to, effectiveness, side effects, frequency of using the methods, and different ways of taking methods. And when you do that, you don't go down the rabbit hole and say, IUDs have this characteristics, implants have these characteristics. It's more a broad exploration of how they feel about the different ways that methods can vary. So for example, you can say things like, there are methods you take once a day, once a week, once a month, or even less frequently. Is that something that makes a big difference to you? So you're helping patients to think broadly about what matters to them without asking them to put it onto a specific method, because maybe they have a strong emotional reaction to the IUD, right? Because of things that they've heard about it in their social networks. But maybe they would love to have something that they don't have to think about ever, right? So by asking them to think broadly, you're then going to allow them later on to weight how their preferences relate to each other. It is really important to talk about effectiveness, right? People care about effectiveness. For not everyone is it the most important thing, but everybody does care about it somewhat. And there's a lot of misinformation out there, misconceptions about the relative and absolute effectiveness of different methods, right? So we should absolutely be providing counseling about that. To do that, best practices for that are to use natural frequencies. So don't say 1%, say 1 in 100, right? The frequently used visuals we use can be somewhat deceiving because it kind of implies that condoms aren't effective at all because it's down at the bottom, right? So really being clear that condoms, still 80 out of 100 women do not get pregnant in a year. And using visual aids can be helpful for that. I always really want to make sure, even though I have such limited time, to mention counseling about side effects because it's really important and because we do a pretty bad job about it, I think, in general, in our field, in just talking about counseling writ large in medicine about side effects. So for the context of contraceptive counseling, I really encourage us to really make sure that we ask people about how they feel about menstruation. And do they really care if they have irregular periods? Do they care if they have heavy periods? Do they care if they not have a period? Because most methods have some impact on that. And by focusing, and people have strong feelings about it. And so by eliciting that, we can do a better job of making sure that we get the information we need to support people to make a decision about what method best meets their needs. And then in addition, in terms of side effects, I encourage us to talk to patients, ask them what they're worried about. If we don't ask them, they might not tell us, and they're going to go home and they're going to have the same concerns they had when they came in, right? Ask them about things person has heard from friends, right? So we can understand what her concerns are. And then it's really important when we elicit those concerns to respond in a respectful manner. So, and the reason why I say this particularly is our qualitative work has really highlighted the fact that patients don't feel respected. They feel very much like we dismissed their concerns, that their friend had, felt like their hair came out on the marina, and we just say, that's not true, right? And that makes people feel, as indicated by this quote, that we're hiding complications, we're hiding side effects. Instead of saying something more like, I'm really sorry your friend had that experience. I can tell you that that's not common, and everybody's different. So just because your friend had it doesn't mean that it's going to happen to you. So acknowledge the lived experience, like honor the lived experience, but also honor the data at the same time. So then you've stated that you're interested in her preferences. You've elicited informed preferences for method characteristics, like I said, including menstruation, effectiveness, how she takes the method, how often she takes the method. And then what you do is provide scaffolding for decision making. Given her preferences, what information does she need? And in that context, we're supporting patients to make a decision that's aligned with their preferences. But it's really important that we not state preferences that are not based on those preferences. That we don't state our own preferences that are not based on what patients have told us. So to give you an example of what that can look like, saying something like, I'm hearing you say that avoiding pregnancy is the most important thing to you right now. In that case, you may want to consider either an IUD or implant. Can I tell you more about these methods? So again, this ends up the same place that a tiered effectiveness approach ends up, with leading with IUDs and implants, but you've gotten there because the patient has told you that's what she cares about. And so by doing that, the process has made the patient feel honored. Or you mentioned that it's really important to you to not have irregular bleeding. The pill patch ring and copper IUD are good options if you want to hear more about those. Okay, so that's the kind of very, very brass tacks approach to shared decision making that I want you to carry away with you. I want to recognize that sometimes it's particularly because of time pressure and because of the fact that our biases are prevalent and difficult to fully acknowledge, it can be helpful to have tools that support us in providing person-centered care, including shared decision making. So these can be digital or non-digital. This is like the really brass, like really quick overview of some tools you can use. But let's take this case, for example, of a woman who says, I've heard from you that the absolute most important thing is not getting pregnant. Or so you've heard this from her and you're saying back to her, I've heard from you that the absolute most important thing is not getting pregnant and that you also want something that makes your period lighter but keeps it regular. Let's look at this chart to explore your options. So this is a chart from the Family Planning, or actually no, it's now called the Reproductive Health National Training Center, because I took the planning word out because of this conversation about planning and intention. So it's the Title 10 National Training Center. And so this is different from the tools that are often used that only talk about effectiveness, that only have effectiveness on them. This is a tool that places effectiveness in the context of other method characteristics and can be a job aid you can use to support patient-centered shared decision-making. So in this context, going back to this case, this person does not want to get pregnant. It's very important to her not to get pregnant, and also wants something that makes her periods lighter but keeps it regular. So you point out for menstrual side effects. This is the ones that fill that aspect of her preferences, and these are the ones that are the most effective. And so visually, you can see that those two preferences do not overlap, and this allows people to weigh for themselves how important the different preferences are. And then just to close, I want to mention, Jenny already mentioned this, that we recognize how shared decision making is hard from a time perspective, from a skill perspective, from everything else. So we developed this tool called My Birth Control, which is designed to support a shared decision making with counseling. It's a patient-centered tool that walks patients through the process of thinking about their preferences and then gives that information to patients, providers, so they can engage in a higher level conversation with their patients about what decision about contraception best meets their needs. And in our cluster randomized trial, we found, this was published in the American Journal of OBGYN, patients who used the tool had a more positive experience of care, had more knowledge, were more satisfied with their information about side effects, and had higher decision quality using the decisional conflict score. So this is something that we have available, and we're working on dissemination plans, both for free and commercializing it, because I think that contraceptive counseling is hard, and anything that we can do to make it easier for providers to be able to provide this care is in a standardized way is important. So I know I'm almost at time, but just in conclusion, sorry for going so fast at the end, I just want to say that it is my strong perspective that providing person-centered contraceptive care is an ethical mandate that supports both reproductive autonomy and not making assumptions about what people should want with respect to their reproduction, and also health equity. And shared decision-making is one approach to do that allows you to explicitly focus on patient preferences in a structured way. And you can use digital and non-digital tools to support you in providing this care. So thank you so much.
Excellent. Thank you so much, Dr. Dehlendorf. And I know Mary Landry, one of our faculty, has been using your app in University Health Services. We have a few minutes for questions, and I said I would moderate that. So I'd be happy to have folks either put questions in the chat or jump in. And if you do jump in verbally, we'd love to see your video.
I'm going to jump in. This is Mary Landry. Christine, thank you so much. Wonderful talk. I am very interested to know from your perspective and your research, as well as your personal experience, where you feel in the future, post-pandemic, telehealth might, for contraceptive counseling and access, might have a role to support reproductive autonomy and health equity in the future.
Thank you so much. Yeah, I think anything that provides more options to people to get the reproductive health care that they need is a person-centered approach, right? So people have asked me before, given that I'm a contraceptive counseling person, how I feel about over-the-counter hormonal contraception, right? Which is something that is, you can get pharmacy prescribed hormonal contraception in California. And I'm a huge fan of it, because if people don't want to come in and talk to me, then I'm not going to force them. That's not person-centered, right? And I feel the same thing about telehealth, right? If we can get people the care that they need by over the phone or by video, and they don't have to come in, that's great. That said, I do have concerns about the ways that that it can be something that the financial considerations will then take over, and instead of offering more options for people, we end up limiting options for people by eliminating the option to come in and talk to a real life person, right? And putting up barriers to people getting the care that they need instead of providing more options for care, right? So I think that is something that is going to be an evolving story. How can we both provide flexibility and where people can access care, and how people can get care online using, like My Birth Control, offering it online, I think is really important, so people can interact with it separate from a clinical care context, right? So to do that, I think is really important, but we have to put up guardrails, because we deprioritize reproductive health care every which way from a policy and clinical care perspective. And if it can be cut, it will be cut. And so we need to really recognize the ways that can interfere with people getting the care that they need.
Thank you. Very important point.
And Christine, Katie Anthony asks in the chat if you have any guidance or resources for doing contraceptive counseling during pregnancy.
Yes, so we have actually just developed a version of my birth control, which is in the peripartum context. We're actually working with some people in Michigan to roll that out at University of Michigan. So I think that it is both the same and different contraceptive counseling during pregnancy. I think that there is amplified concerns about the ways that stratified reproduction plays out, because counseling for people in the context of when they're currently pregnant, I think brings up a lot more biases and a lot more potential for really kind of saying, well, don't you want an IUD within 10 minutes of delivery, right? But it's also ultimately not that different in terms of, maybe some women can't start for 35 days combined hormonal contraception, but it's a really pretty minimal difference in terms of what methods are available to people. One piece that I feel like is really important is the short interpregnancy interval. I have strong feelings about that, and how we have this kind of absolute idea that like we need to tell people that they shouldn't get pregnant for, some people say 18 months, other people say 6 months. I think the reality is what we should do is inform people about the data, which I think is only good up to 6 months, and let them make an informed decision, but for themselves about what pregnancy spacing might look like for them. So, if you want to reach out to me, I can absolutely share our tool that we have, which goes into, you can't really talk about pregnancy or birth control after pregnancy without also talking about sex and mood and breastfeeding. So we also have some light touch things related to that in our peripartum version of my birth control.
And I think we have time for one more question if someone wants to hop in.
So lactation, someone says that, someone has that here. Is the particular, how do I talk about immediate postpartum depo? Is that the question?
This is Katie Sempenny. Hi, I'm one of the generalists here, and I was just wondering, there's, so many women have a concern that progesterone-only options could also affect lactation. And I'm wondering what your thoughts are on kind of like that, like honoring the patient's lived experience and melding that with the data, and how to provide high-level counseling in regards to that.
Yeah, it's a great question. And I think, like so many things with contraception, we don't really have a great, the side effects are, people's physiologic reactions to contraception are so varied, right? That I don't think we can ever definitively say to someone, no, you will not have a decrease in lactogenesis if I give you Depo before you leave the hospital, right? I just think that's the reality. We don't know, because the statistics are an average across people, right? And some people get lost in that. So I think what we can do is say, kind of the example I gave with hair loss is say, in general, what the studies have found is that this is not something that will have an impact. But I also want to honor that this may be your lived, if it's something that happened to her in the last round when she was pregnant before, or when she postpartum before, I would absolutely honor that. And if it's really important to her to not, to be able to try to establish successful breastfeeding, I would absolutely counsel her in the context of that. I'm not sure if that answers your question, but for me, it's like, it's kind of clear cut. Like, we just honor that, and we provide her with the support and information, the information that we have about data of averages, acknowledging the limitations of the data of averages, which I think we don't often do.
Yeah, I think that's great. I guess I'm a little bit also wondering how you would approach it in general if when you're providing that contraceptive counseling as during the pregnancy, would you bring that up for each individual? Because I would say historically, at least locally here and many places, I think we say we recommend progesterone only options while you're breastfeeding because they won't affect your milk supply. But would you recommend kind of in that kind of context, always bringing that potential up?
And Christine, could you give the 30-second version of your answer since we need to close?
Yeah. So it sounds like your context is a little different than our context. So I think that I just in general don't think that we need to be doing EPO. I think the question for me is about any immediate methods as opposed to delayed. For me, delayed methods, I think it's a preference sensitive decision, and people can use estrogen containing methods after their breastfeeding is established without me having any concerns, right? And I don't think most people need birth control in the first 2 weeks postpartum, right? So for me, it's I would just in general not be talking to people in the context unless there was a specific concern about what contraceptive method they necessarily absolutely need prior to establishing breastfeeding. And then if there is a concern for early birth control, then maybe I would engage with that conversation.
Fantastic. Thank you so much. And there have been some requests in the chat for sharing some tools, which we can do. So everybody join me in thanking Christine, and really appreciate your talk. Fantastic.
Thank you so much. I hope I answered your question, Katie.